UCT-Africa virtual morning Zoom meeting. My name is Dr. Hervin Heeroo. I'm one of the registrars at UCT. So we are going to be presenting a case of skull-base osteomyelitis this morning, as well as having a presentation on the topic. My consent was obtained from the patient, and all my content is referenced. So my case presentation is of a 40-year-old male patient. He presented with a 6 months history of left otorrhea, followed by a 3-week history of an enlarging left post-auricular swelling. On examination, he had no meningism, no cranial nerve fallout, and no focal neurology. Automicroscopy revealed a 5% anterior perforation with granulation tissue visible through the perforation. 12 mL of pus was aspirated from the post-auricular swelling and sent off for MCS, TB, and fungal culture. CT scan was done and showed coalescent left mastoid air cells with bony erosion of the tegment. The otic capsule and facial nerve canal were intact. The left transverse and proximal sigmoid sinus feeling defects were noted. No intracranial collections or infarcts were noted. So a left cortical mastoidectomy was done, and pus and tissue were sent off for MCS, TB, fungal culture, and histology. The lab results were as follows. So the patient was newly diagnosed HIV positive with a CD4 count of 186 and a viral load of 332,858. Pus and tissue cultured Staphylococcus aureus that was sensitive to cloxacillin, and Streptococcus pyogenes sensitive to penicillin. No acid-fast bacilli were observed, but TB culture is still pending. No fungal hyphae were observed. Sputum gene expert was negative, and the histology showed only inflammation tissue, no malignancy. An audiogram was done, which, as you can see, shows a left mild to profound mixed hearing loss. Intravenous cloxacillin and ceftriaxone was started for 6 weeks. Anticoagulation of dural venous thrombosis was started with clexane 12 hourly. The patient will require definitive mastoid surgery once the acute infection resolves. So the topic for presentation this morning is skull-base osteomyelitis. Osteomyelitis is an inflammatory process of bone primarily caused by pyogenic organisms. Skull-base osteomyelitis mainly involves the temporal bone and the sphenoidal bone. It commonly occurs as a complication of malignant otitis externa and chronic mastoid infection. It commonly occurs as a complication of malignant otitis externa and chronic mastoid infections, or secondary to sphenoidal sinusitis. Malignant otitis externa primarily affects the temporal bone and is the most frequent cause of skull-base osteomyelitis. Skull-base osteomyelitis is more common in immunocompromised patients. These conditions may produce an alkaline pH in the cerumen with diminished immune response, that is impaired phagocytosis, poor leukocytic response, and impaired intracellular digestion of bacteria, hypoperfusion, and microangiopathy, which predispose the patient to skull-base osteomyelitis. The most common bacterial cause is Pseudomonas aeruginosa. And other bacteria include Staphylococcus aureus, Staphylococcus epidermidis, Salmonella, Proteus, non-tuberculous Mycobacterium, Treponema pallidum, and Klebsiella. The most common fungal cause of skull-base osteomyelitis is Aspergillus, and fungi such as Candida, Cryptococcus neoformans, blastomycosis, and mucormycosis can also cause skull-base osteomyelitis. So the pathophysiology of skull-base osteomyelitis can be explained on CT images. As you can see, the left coronal CT image shows the spread of infection, as shown by the green arrows, in a patient with autogenic skull-base osteomyelitis of the temporal bone. It is usually secondary to otitis externa. So from the external auditory canal, the infection reaches the temporal bone through the fissures of Santorini. The infection can spread antero-inferiorly to the parotid, masticator, or parapharyngeal spaces, medially to the carotid or perivertebral spaces, and even into the spinal canal. Intracranial spread can also occur by extension through the petroclival synchondrosis. The right axial CT image shows the spread of infection, also by the green arrows, in a patient with autogenic skull-base osteomyelitis of the temporal bone. The infection typically spreads by means of vascular and subfascial plates and can reach various skull-base foramina. The facial nerve is usually affected when the stylomastoid foramen or mastoid process is involved. The infection can spread medially to the jugular foramen with involvement of cranial nerves 9, 10, 11, and the jugular vein. The carotid canal can also be affected and can cause vascular complications. If the infection progresses, it can reach the foramen spinosum and foramen ovale. So skull-base osteomyelitis typically presents with severe and profound otalgia due to the involvement of temporal, parietal, post-auricular, and retroorbital areas, with the patient spiking a fever, having oral fullness, and foul, purulent otorrhea. The diagnostic criteria set forth by Cohen and Friedman include pain, exudates, edema, and granulation tissue of the external auditory canal, and a positive technetium-99m scan. Cranial nerve involvement commonly occurs in skull-base osteomyelitis as the disease progresses. The facial nerve is the most common and the first cranial nerve involved when the infection spreads subtemporally at the stylomastoid foramen. With further posteromedial spread, cranial nerves 9, 10, and 11 may be affected with jugular foramen involvement. Cranial nerves 5 and 6 are affected when the petrous apex is involved. An involvement of the sympathetic plexus along the internal carotid artery can produce Horner's syndrome. Untreated skull-base osteomyelitis may lead to meningitis, brain parenchymal involvement, abscess formation by intracranial empyema, and venous sinus thrombosis. So as part of the lab investigations, so these usually illustrate a mild elevation of ESR, CRP, and leukocyte counts. Biopsy with histopathology, microbiology, TB culture are necessary to rule out malignant disease. Repeated biopsy and culture may be required in those cases in which the first culture result is negative, or to rule out an occult malignancy in patients who have persistent disease despite appropriate antibiotic therapy. So for fungal pathogens, silver stain on histological sections may identify the organisms. The imaging techniques used to diagnose skull-base osteomyelitis are non-enhanced and contrast-enhanced CT, enhanced MRI, and nuclear imaging. CT is the best option for evaluating bone erosion and demineralization. Contrast-enhanced CT can show involvement of the skull base for foramina and vascular complications. MRI is useful for evaluating the anatomic location and extent of the infection, and it can show bone marrow infiltration, intracranial and perineural extension, and the involvement of lateral structures, that is parotid gland and temporomandibular joint. Nuclear imaging can help to confirm bone involvement with high sensitivity. There's currently no consensus in the literature regarding the preferred imaging modality to assess disease progress or relapse, as well as treatment efficacy. We should remember that most hospitals in developing countries do not have the ability to assess disease activity with nuclear imaging. Therefore, we have to rely on conventional imaging modalities such as CT and MRI. In this chart review from Australia by Anger and al., CT was noted to be the most commonly used imaging method to diagnose and monitor skull base osteomyelitis. The authors made the following recommendations. Firstly, follow-up imaging should be performed not as early as 2 months after the initial scan if there is no clinical evidence for disease progression, because the highest progression rate was found within the first 2 months after the initial CT scan. An MRI should be the preferred modality rather than CT, because CT scans fail to detect progression or regression in up to 80% of patients after 4 to 9 months, while MRI examinations could reveal changes at a higher rate compared to CT. So the mainstay treatment for bacterial skull-base osteomyelitis includes a full course of culture-directed intravenous broad-spectrum antibiotic therapy for a minimum of 6 weeks. For fungal skull-base osteomyelitis, high-dose amphotericin B or liposomal amphotericin B is recommended. Hyperbaric oxygen therapy has recently been suggested as a treatment technique that improves tissue oxygen contents and host defenses, especially in chronic refractory skull-base osteomyelitis. And surgical procedures may involve debridement, necrotic tissue, bone biopsy, and culture. Clinical and radiological criteria can be used to distinguish bacterial and fungal skull-base osteomyelitis. Bacterial osteomyelitis, skull-base osteomyelitis is mostly of osteogenic origin with involvement of cranial nerves 7 to 12, while in fungal skull-base osteomyelitis, the origin is usually rhinogenic, with higher prevalence of orbital, vascular, and intracranial extension, palsy of cranial nerves 3 to 6, and permeative bone destruction. Hypointensity on T2-weighted MR sequences and hyperdensity on unenhanced CT also favors fungal involvement. And again, clinical and radiological criteria can be used to distinguish aspergillus and mucor skull-base osteomyelitis. To note that mucor skull-base osteomyelitis in comparison with aspergillus skull-base osteomyelitis shows faster disease progression, a black scar, cerebral infarcts, and heterogeneous post-contrast enhancement. On the other hand, aspergillus skull-base osteomyelitis shows intracranial homogeneous enhancing masses and greater incidence of concurrent pulmonary disease. Recently, essential or atypical skull-base osteomyelitis has been identified as conditions unrelated to autologic pathology. And as you can see, the usual cause of typical skull-base osteomyelitis is necrotizing otitis externa, while for atypical skull-base osteomyelitis is usually advanced paranasal sinus infection. And the organisms differ as well. So for typical skull-base osteomyelitis is usually Pseudomonas aeruginosa, while for atypical skull-base osteomyelitis, it's usually Staphylococcus aureus. So the differential diagnosis of skull-base osteomyelitis includes, as we say, typical skull-base osteomyelitis, atypical skull-base osteomyelitis, rheumatological diseases, most commonly granulomatosis with polyangiitis, and IgG4-related disease. Tumors are malignant, most commonly nasopharyngeal squamous cell carcinoma and metastasis, and benign tumors such as fibrous dysplasia. There's a type that's called pediatric clival osteomyelitis, which is a very rare variant of skull-base osteomyelitis that usually affects kids. It generally occurs secondary to the direct spread of an infection to the clivus bone from contiguous structures. Some case studies have reported a link between clival osteomyelitis and different pathogens, such as Enterococcus faecalis and MRSA, and anaerobe Fusobacterium necrophorum. So in conclusion, skull-base osteomyelitis is a life-threatening complication that can be misdiagnosed for malignancy. And although this condition is rare, one must be able to distinguish the clinical and radiological findings to decrease delayed diagnosis and undertreatment of the condition. And finally, early and aggressive use of long-term intravenous broad-spectrum antibiotic treatment is crucial. These are the references which I use for my presentation. Thank you for your attention.
Thank you very much. Great. Did you come across much about tuberculosis?
There have been a few case reports, but there's been no randomized controlled trials and much systematic reviews, because those studies were mostly performed in developing countries where TB is not very prevalent.
Yeah.
But I did come across a few case reports.
We had enough here to go look at that, and we talk about the two different groups of it might be good to look at that aspect. I don't know how many testing is on our books. And the other issue is the hyperbaric oxygen. Is that are those recent papers, or are they just re-quoting old papers? The hyperbaric oxygen has fallen into this paper in general.
Yeah, there's much debate in the literature. So it has been suggested, but it's not been widely adopted by many centers.
Yeah, okay. Yeah, we might want to be cautious about just re-quoting what's been contentious in the past if we didn't have evidence that actually works. What's your sense about that?
But I haven't seen any evidence for it yet.
Yeah, yeah. Yeah, we used to be used a lot for osteoarthritis, etc., but all those studies are actually being questioned, and those hyperbaric oxygen receptors are actually shut down. So just be careful you don't perpetuate something, but because in the literature there is good evidence.
That also comes at significant cost.
Yeah.
Okay. Can you just clarify something in terms of terminology for me? I mean, it's acute skull-base osteomyelitis synonymous now mastoiditis, because that first case you presented, I would have thought was a coalescent acute mastoiditis secondary to chronic otitis media with transverse thrombosis, as opposed to classic skull-base osteomyelitis necrotizing otitis external.
Yeah. So this patient did not present with any tenderness. He only presented with a chronic ear discharge, followed by a 3-week history of a post-auricular swelling. And on examination, there was granulation tissue within the middle ear cavity. So he was taken for cortical, thinking that it could be an acute mastoiditis secondary to cholesteatoma. However, in theater, no squamous debris was found, and the first swab cultured Staphylococcus aureus, and CT demonstrated skull-base involvement.
Yeah, I'm still a bit confused because you can still find all those features in mastoiditis. Commonly Staph aureus, you probably can also find granulations during the middle ear and sort of cavities. So I mean, it leaves me still a bit confused, to be honest. Maybe the chronicity of it, as you say, and atypical presentation, the fact that he's immunocompromised. Most towards a skull-based osteomyelitis.
Well, Prof, like, as has been said, I think the presentation was a very classical one we might expect. The ear pain, the necrotizing otitis external, but the CT scan was what drew more attention towards the skull-based osteomyelitis. Back home, I've seen one or two cases. They were immunocompromised people who presented with otitis external that you classically would treat the normal way, but it doesn't really resolve, and then it continues with all the possibilities of cranial nerve involvement. But eventually, when we are able to exclude, when we are able to test for immunocompromised, like TB or HIV or others, we tend to see that it's the immunocompromised state which rather predispose them to having those kind of.
Thank you very much. Great.
Thank you. Are there any other comments? So thank you for your attention. Our next meeting will be Friday. Thank you. Oh, it's African Head and Neck Society. All right. So our next meeting will be next week, Wednesday. Thank you for your attention.
Thank you. Well done.